All right, today we've got a really interesting case. A 67-year-old male,
Okay.
significant smoking history,
Mm-hmm.
CPD, and he's just one day post-op after a hernia repair.
Right.
The notes say he's got tachypnea, pyrexia, and tachycardia.
Oh, wow.
So given all that, what's your biggest initial concern here?
Well, in this kind of scenario, I'd be most worried about uh, post-operative pulmonary atelectasis, especially with the abdominal surgery pain and his COPD history. He's just really high risk.
Can you sort of walk us through the pathophysiology behind that? Like, why is this patient in particular so susceptible?
Sure. During abdominal surgery, anesthesia and pain meds, they can really suppress breathing.
Right.
And of course, the incision itself hurts, so that makes him take shallower breaths, cough less.
Makes sense.
So for this guy, he's already got too much mucus, right, from
Yeah.
the smoking and the COPD.
Yeah.
And if he can't clear it well, it's just going to build up in his airways.
Oh, I see.
And that blockage, that's what causes those lung segments to collapse. That's the atelectasis.
Okay, that's really clear.
Yeah.
Now, we got to consider other things too, right? I mean, what else could be going on?
Absolutely. We can't just jump to conclusions.
Right.
Atelectasis is the most likely, but we got to keep a broad differential.
Of course.
Pneumonia, although it's probably too soon after surgery, still got to think about it.
Yeah.
And then there's pulmonary embolism, especially given his age, lack of mobility after surgery,
Mm-hmm.
deep vein thrombosis, can't rule that out either, could lead to a PE if a clot breaks off.
Right, right.
Then you've got your other infections, UTI, cellulitis, surgical site infection, all those could cause these symptoms too.
Okay, so we're thinking broadly. Sounds like a good physical exam is going to be crucial here.
Absolutely, got to be systematic.
So how would you approach examining this patient? What are the key things you're looking for?
Well, first things first, it's always ABCs. Airway, breathing, and circulation.
Right, the basics.
Going to make sure his airway's clear, assess his breathing, how much effort he's using, and then see how his circulation is doing.
Okay, let's focus on the respiratory exam for a minute. What would you be looking for specifically that would make you think, yep, this is atelectasis?
All right, so on inspection, you might see him breathing fast using those accessory muscles. That's a sign of respiratory distress.
Gotcha.
Then you percuss over the area where you suspect the collapse,
Okay.
and you're going to hear dullness there. That suggests consolidation.
Interesting.
And then when you auscultate, you might hear diminished or even absent breath sounds in those collapsed segments. You might even hear some crackles, too.
Okay, that makes sense. You mentioned checking his circulation before. What are you looking for specifically there?
Well, we want to monitor his heart rate, obviously, see if he's tachycardic, and then blood pressure, too, make sure it's not dropping. Could be a sign of something more serious.
Right.
And then you check his neck veins, look for distension, maybe a raised JVP.
Okay.
That could suggest heart failure, which could be contributing to his breathing problems.
All right, so we've done a thorough exam, got a good idea of what's going on. What about investigations?
Right.
What tests do we need to confirm the diagnosis and rule out other possibilities?
Chest x-ray is essential. Got to see those lungs.
Of course.
See if there are any areas of opacification, collapse in those lung segments. Plus, it helps rule out pneumonia or other lung issues.
What about blood work?
Oh, yeah, definitely. Complete blood count.
Mm-hmm.
Check his white cell count. Look for signs of infection.
Makes sense.
And then inflammatory markers like CRP and ESR.
Right, right.
They help us tell the difference between inflammation and infection. And then we need an ABG,
Uh-huh.
arterial blood gas. That tells us his oxygen and carbon dioxide levels. Really important for knowing how well he's breathing and if he needs extra oxygen.
Yeah, you mentioned pulmonary embolism earlier. How would you go about investigating that?
If we're really thinking PE, based on the history and exam, we'd go for a CTPA.
Quick.
CT pulmonary angiogram. That lets us see the pulmonary arteries directly, see if there's a clot blocking things up.
Before we move on, can you just quickly sum up those key investigations again?
Sure. So for this patient, we're talking chest x-ray, complete blood count, inflammatory markers, ABG, and if we're suspicious, a CTPA. Those are the tests that will really guide our management decision.
Okay, fantastic. That's a great overview of the initial approach to this patient.
So we've talked about the investigations. Now let's dive into how we'd actually manage this patient, assuming it is post-operative atelectasis.
Okay, so what are the immediate steps? What do we need to do right away to stabilize him?
The most important thing is making sure he's getting enough oxygen.
Right.
We'll monitor his oxygen saturation closely, give him supplemental oxygen as needed.
Of course.
Now, we have to be careful with the oxygen, though, because of his COPD.
Yeah, you mentioned that earlier. Can you explain why that's such a concern?
Sure. In COPD patients, their body kind of gets used to having low oxygen levels all the time,
Okay.
and their drive to breathe starts to depend more on that low oxygen rather than high carbon dioxide levels.
I see.
It's called the hypoxic drive, and if we give them too much oxygen, it can actually suppress that drive, make them breathe less.
That's pretty counterintuitive.
It is, so we have to be really careful.
So how do we make sure he's getting enough oxygen without making things worse?
Well, we use a controlled oxygen delivery system, like a nasal cannula or a Venturi mask.
Mm-hmm.
That lets us give him a very specific concentration of oxygen. We start low and adjust as needed based on his saturation levels and how he's doing clinically.
And we can recheck the ABG after, what, 30 minutes or so?
Exactly. Make sure his CO2 isn't creeping up.
Okay, that makes sense. So beside the oxygen, what else needs to be done right away?
Pain management is absolutely crucial.
Right, so he can breathe deeply and cough.
Exactly. We need to make sure he's comfortable enough to do that.
So we might need to adjust his pain meds, maybe give him something stronger.
Yeah, might need to go with IV opioids or even a PCA pump.
Okay. Now, what about respiratory therapy? What role do they play in all of this?
Oh, respiratory therapists are essential. They're the airway clearance experts. They'll do things like deep breathing exercises, incentive spirometry, chest physiotherapy,
Chest physiotherapy, what's that exactly?
things like percussion and vibration, basically helping loosen up those secretions and get the lungs to expand better.
Ah, okay, so it's all about mobilizing those secretions.
Yep, and we can help with that too.
How so?
Well, hydration is key.
Oh, right, to thin the secretions.
Exactly. Encourage him to drink plenty of fluids if he can tolerate it.
Yeah.
And if needed, we can give him IV fluids. Sometimes we might even prescribe a mucolytic medication to help break down that thick mucus.
That makes sense. Now, we talked about the possibility of infection. What about antibiotics? Do we start them right away?
Not necessarily. We only want to use antibiotics if we're sure there's an infection.
Right, so we don't contribute to resistance.
Exactly. We'll wait for the blood and sputum cultures to come back before making that decision.
And if it is an infection, we'll tailor the antibiotic based on those results.
Absolutely. We want to target the specific bacteria involved.
Now, we've been focusing on atelectasis,
Yeah.
but we also talked about things like pneumonia and pulmonary embolism. Does our management change if we suspect those?
It does. If it looks like pneumonia, based on the exam and x-ray, we'd start broad-spectrum antibiotics while waiting for the cultures.
Okay.
And if we're worried about a pulmonary embolism, then we need to start anticoagulation right away.
Heparin.
Yeah, heparin or a similar medication.
To prevent more clots and further complications.
Exactly. So it really depends on what we find.
This has been a really thorough discussion about managing these post-operative respiratory issues.
Yeah.
Anything else we need to keep in mind before we talk about prevention?
I think the most important thing is just to remember to monitor the patient closely. Things can change fast.
Of course.
We need to keep a close eye on his vitals, his oxygen saturation, and how he's responding to the treatments we're giving him.
Regularly reassess.
Exactly. We might need to repeat the x-ray, the ABG, adjust the management plan as we go. It's all about being proactive and responding to his needs.
Okay, so we've covered how to recognize and manage these post-op respiratory complications. But what about preventing them in the first place? What can we do for patients before they even have abdominal surgery?
Well, for this patient, the biggest thing would have been quitting smoking.
Right, of course.
Smoking not only makes more mucus, but it also messes up those little cilia in the airways, the ones that help clear it out.
So even if he'd quit for a little while before surgery, would that have helped?
Oh, absolutely. Even a few weeks can make a big difference.
Really?
Yeah. Studies show that lung capacity starts improving within a week of quitting, and the cilia start working better too.
Huh. So that means better mucus clearance, lower risk of complications?
Exactly.
Okay, what about a COPD? Anything we could have done for that beforehand?
Definitely. We'd want to make sure his COPD was as well managed as possible.
So like adjusting his meds?
Yeah, maybe adjusting his meds, making sure he's using his inhalers correctly. We might even recommend pulmonary rehab.
Pulmonary rehab.
Yeah, it helps improve exercise tolerance and lung function.
So it's all about optimizing his breathing before he even gets to the OR.
Exactly. Now, during the surgery itself, there are things we can do too.
Like what?
Well, first, we try to keep the anesthesia time as short as possible.
Makes sense.
And then, when we're ventilating him, we use lung protective strategies.
What does that mean?
Basically, we use lower tidal volumes and lower airway pressures.
Okay.
It reduces stress on the lungs, makes ventilator-induced lung injury less likely.
So we're being gentle with his lungs.
Exactly. And then after surgery, the most important thing is getting him moving as soon as possible.
Early mobilization.
Yep. Getting him up and about helps expand the lungs, improves circulation, and reduces the risk of atelectasis and DVT.
So movement is key.
It really is. And of course, good pain management is essential too.
Right. So he can take those deep breaths and cough effectively.
Exactly. And we keep encouraging those deep breathing exercises, the incentive spirometer, all that good stuff.
Well, this has been a really comprehensive look at post-operative respiratory complications. We've gone from the first signs and symptoms all the way through management and prevention. Any final thoughts for our listeners out there who might encounter these kinds of cases?
I think the main takeaway is that it takes a multi-pronged approach.
Right.
We got to be good at identifying at-risk patients, be thorough in our exams, and be proactive about prevention.
So early recognition, prompt action, and good patient education are key.
Absolutely. That's how we get the best outcomes and make these complications less common.
All right, that's a great point to wrap things up on. Thanks for joining us for this deep dive, and we'll see you next time.